morning. This is Dr. Alice Lee. Welcome to iCubed, episode number 17. Wow. iCubed is AMN's newest screencast, and thank you for listening this month. I have a return guest, Dr. Mary Harper, my wonderful leader here at Banner Baywood Medical Center.
Good morning.
Please introduce yourself.
I am Dr. Mary Katherine Harper, Medical Director here for Banner Baywood. I have the most amazing staff ever.
I would have to agree with that. Well, welcome. We're going to be talking about a new subject this month, and hopefully we'll learn together what problem this patient has. So let's just dive in. She is an 89-year-old female who comes into the emergency department with abdominal pain for 3 days, okay? She comes in complaining of right upper quadrant pain, upper abdominal pain, and the right rib pain. After she fell, she tripped on her boot. She was wearing a boot because she had a foot injury. So she tripped over that and fell onto her right side, injuring her right rib cage area and right abdominal area. She reports being nauseous, being constipated, and she's been vomiting. Looking at her past medical history, she has a history of depression, DJD, osteoporosis, hemorrhoids. She's had past surgical history of a right hip replacement. She's had a right shoulder done. She's had a vaginal prolapse surgery, rectal seal repair, urethral suspension, and hysterectomy.
Just a few.
Yeah, really. Not too uncommon for our patient population. Social history, she's never smoked. She drinks occasionally.
Was she drinking when she tripped over her shoe?
Excellent question. No, she was not in this case. So her vital signs upon presentation, she's got a blood pressure of 100 over 64, heart rate is 69, respiration to 12. Saturations are good, 96%, and she's got a temp of 98.4, so afebrile.
So overall for that age, pretty normal vital signs.
Pretty good.
Blood pressure a little bit low, but She may be beta blocked. She may be...
Exactly.
So
excellent thoughts, right. So looking at her, she's laying in a bed. She looks actually pretty well in terms of just general appearance. She's alert. She's conversant, cooperative. She has dry mucous membranes. It seems like everybody in Arizona has dry mucous membranes, right? And poor skin turgor. On exam of her chest, she's mildly tender in the right anterior lateral aspect of her rib cage. But there's no crepitus, there's no discoloration or bruising in that area. Her belly exam, it's actually very soft. She's tender, though, in the right upper quadrant. She's not guarding. She's got no rebound, and her bowel sounds are normal.
is she on blood thinners?
No, she is not. Any thoughts at this point?
Everything.
So differentials, any kind of studies you want to order?
Absolutely. So your differential, there's two things we need to think about. Is this traumatic?
Yeah.
So does she have rib fractures? Could she potentially have hemothorax?
Right. Excellent.
Could she have ruptured, liver laceration, things like that? So is this more trauma-based, or is this just an incidentalloma and this is more medicine and she also just happened to trip and fall? So now you have to think of all the medical stuff that could happen. I didn't hear anything about, fevers or cough, but certainly the base of your lung is in that right upper quadrant. But there's also a lot of real estate, particularly for elderly, your gallbladder, liver.
Excellent.
So from a workup standpoint, granted, she's in her 80s, so that's a fairly young patient for our population, but she's going to get everything. So you're going to order the entire abdominal panel. So you're going to get a CBC, a CMP, lipase. She's older. I would still get coags, especially with recent trauma. And then imaging, I don't even know that I would. X-ray, I'd probably just go straight to a CT scan, to be completely honest. And I would do her chest, abdomen, and pelvis with contrast.
So the preponderance of your thinking at this point is sort of trauma sort of related, right? So
it's more trauma, but
I thought of that too, of course.
Also, elderly, right upper quadrant, could this be cardiac? Particularly with our population, you can't pigeonhole anything. You've got to think very, very broad spectrum. So she's certainly going to need an EKG. And I'd honestly probably get a troponin as well. Could she potentially have a cardiac contusion with her fall?
Sure.
She's got nausea and vomiting.
Fantastic.
Got to rule it all out.
Well, abdominal pain in an elderly person has a really, really broad differential, just like you said. This is a limited list of differentials, for her, such as cholecystitis. Maybe it's right lower lobe pneumonia, right? She's fallen. Maybe she's been sedentary and got pneumonia. She may be just simply constipated, right? I mean, if you rule everything out, it would be constipation. Maybe she's got a bowel obstruction and she's got pain. She's vomiting, right? She's not having any diarrhea. A traumatic liver injury, it's right upper quadrant. She's a little tiny thing. She falls ground level. She can definitely rupture that liver or bruise it, right? Ischemic bowel. She's got a soft belly on exam, but she's complaining of a lot of pain, right?
How many of our elderly have completely normal abdominal exams and the CAT scan comes back and blows you away?
Right, exactly. That is a very, unfortunately, common thing we do see in our ER. So ischemic bowel was one of the top differentials for her. Perforated viscous on an elderly who's frail. And lastly, the volvulus in an elderly person is a differential in anytime you see them with abdominal pain. So we'll just proceed. What I did was, just like you said, pretty much like what you said, I ordered a whole panel of things on this person because there were so many things that could possibly be in her, right? Even though she looked stable on the surface, vitals were good, not hypoxic, she wasn't doubled over in pain. But we still have to be very careful with the elderly. So these are some of my results that came back that day, right?
So no leukocytosis. Her hemoglobin, 11.9. It's pretty normal. Do we have an old one for comparison?
Not on this screencast.
Of course not. So this is true medicine. So we don't know if yesterday she was, or
13.
2 days ago she was, exactly.
Right.
Sodium, it's pretty normal.
Yeah.
Potassium normal. I mean, overall, I don't see anything abnormal or concerning.
Yeah. So I
with her workup
agree.
so far.
We get some of
I know it's coming though.
We get some of our other studies back. Here's a urine. We always have to get urines on the elderly with the belly pain and vomiting, right?
Absolutely. So spec gravity is a little up, so she's probably a little dehydrated, probably what's contributing to her ketones.
That's right.
Small blood. So this could be, does she have a little dehydration? Does she have any kidney injury?
That's right.
So there's a whole bunch of things to look into that. Nitrate negative, Luke esterase large. However, that seems to be every single one of our patients that we see.
Yes.
So increased WBCs, again, potentially infection. So I'm sure culture will be pending. Right. RBCs. So this helps us know that this is not more of a rhabdo case.
Right.
This is, she does have RBC. So now I really want to look at that kidney on her CAT scan, especially with her recent trauma.
Right.
Squamous cells. So many bacteria. So you're probably, especially with her nausea and vomiting, does she have any urinary symptoms?
Just the vomiting.
There
vomiting? Was no report of any dysuria, and there's been no fever, right?
This is a tough one because you have all these bacteria, and the question is, do you give her one dose of Rocephin while you wait for cultures? Right. Because certainly she does have bacteria, but also you can get bacteria from other things in the abdomen. So I would also like to see what her CAT scan shows before I start prophylactically treating her, especially with no classic urinary symptoms.
I agree with you. I think that we don't have enough information to make a definitive diagnosis on her. We all should be very careful about treating a urine without confirming that there is clinical relevance, because a lot of times the urine has a lot of epithelial cells, and it just is an unreliable study. And oftentimes, especially in a senior citizen, you have to get a cath urine. You absolutely have to beat that into my staff's head sometimes. You have to get a cath
Me too.
urine. I know it's unpleasant, but we are after the integrity of the studies in order to treat the patient properly. So I did order a CT scan, but I also ordered abdominal films. So these are my flat and upright.
Ooh.
Whoa. What do you think?
That's a lot of air. And I don't think she just needs to toot.
What do you think? Anything remarkable about these films other than that there's a lot of air?
Yes. So
does this narrow your differential down somewhat?
A little bit. So she definitely has an air fluid level on the right side. But
how about the film on the left?
The film on the left, she has almost a double bubble sign.
Double bubble. What does that mean?
Double bubble.
Double bubble.
Volvulus.
Volvulus is a very, very prominent differential. Right.
What else?
I actually have never heard of the double bubble sign. What is that? Explain that.
So it's truly where you see two different bubbles or
right,
two distinct areas of air within your abdomen.
Yeah.
Yes.
Right. So I looked at that and I went,
that's not normal.
Wow, that is not normal. There's a giant bag of air right there, not just the upright, but in the flat. So thank goodness it's not 20 years ago where we had to make a diagnosis based on this and a slow CAT scan. I did proceed with the CAT scan study.
But this is fascinating to me because how many times, particularly with the newer generation, do we hear abdominal films are almost useless and everyone goes straight to CAT scan? So this is phenomenal to see something where you can truly identify pathology.
Yeah, you don't know exactly what it is, but you can see that there is pathology.
It ain't normal.
Exactly. Exactly. So that's a generational change between you and I. When I started all this, we relied a lot more heavily on plain films and the interpretation of the plain films based on the pattern of the plain films. As I went along my practice, CAT-10 became much more prominent in the first line of evaluation radiologic study. So I'm going to show you the CAT scan result, a little clip. What is this?
Holy cow. Again, Houston, we have a problem.
And this is the other view.
Wow. That is a wonderful air fluid level. She is going to buy a few tubes.
Yeah, so I get a report from radiology. And what do you think that was? You're not alone. I didn't know for sure what it was.
Okay, I'm not 100% sure. Okay.
It was volvulus.
And that's what I was thinking, volvulus, but there's so many other things that can
it was volvulus. I wasn't sure what it was exactly, but I suspected volvulus once I saw that x-ray, and the confirmation has to come from a CAT scan, right? So we get the CAT scan, and I called our surgeon, so she took the patient off to the OR to fix her, and the op note.
So the trauma was just a complete red herring.
Correct.
This is why it's so important to not get pigeonholed into anything, particularly in emergency medicine.
Yeah, this case has so many lessons on different levels, honestly. But the op report on this patient came back cecal volvulus. And the procedure that the surgeon performed was a right hemicolectomy. She took out the terminal ileum and the right colon, the entire right colon. And because if you see the findings on the report, the dilated cecum had volvulized up to the right upper quadrant, right? So it was
had such a large area of air in
that right upper quadrant. So 15 centimeters of intestine had volvulized, and it was obviously it must have looked like it was almost going to perforate. So a very thin dot ischemic probably. That's why she took out the surgeon took out the colon, and it was noted there was mercury fluid in the pelvis. You know,
in 10 years of practicing, I've never seen a volvulus, or at least that I know of.
Right, that you know. Well, that's why you're doing these screencasts.
Absolutely.
All right, very good. As you know, Mary Catherine, with my screencasts, I try to focus our learning to 2 points because, we can't keep more than 2 or 3 things in our head at the same time. So, learning focus...
Some more than others.
Right. Learning focus number 1 for this screencast is obviously volvulus.
Not that common of a diagnosis.
No, it's not.
But you can't miss it.
So, just a quick picture of the colon. I did not know this, but, the average width of your cecum is 8.7 centimeters. The average width of your sigmoid is about 5.7. Yep.
That's a lot bigger than I would have thought. Yep. Yeah.
It's interesting. So we'll talk about cecal volvulus, which is what this patient had. Did you know there's actually 3 types of cecal volvulus?
Of course I did. Not.
I did not know either. So very simply, the first type is just an axial volvulus where the cecum twists on itself in the sort of vertical axis. The second type of volvulus was a loop, which is that it is rotated on a vertical axis, but then it also kind of flips it up. It flips up, and I'm guessing that my patient had that because it flips up. Mm-hmm. And then the third type of volvulus is a simple flip up.
Okay.
The simple bending of the cecum, if you will, and it just flips up to the upper quadrant. From the emergency side of things, it doesn't really matter, right? We want to make the diagnosis and call the surgeon. The second type of volvulus, which is actually more common, the sigmoid volvulus is much more common. It has only one type. It just, because of the anatomy of the sigmoid, it can only pretty much flip. It can only flip up to the upper quadrant.
Yeah, sigmoid. So
right. So it just because it's tethered in the way it is anatomically. In terms of just treatment, there's a treatment algorithm I found, and the two types of volvulus are treated very differently, actually. So it's critical that the diagnosis be made in the ER. In fact, with this patient, I remember calling the surgeon who asked me, well, is it cecal or is it sigmoid? Because there's a critical difference in the way. If it's sigmoid, you go to endoscopy. If it is cecal, you have to do surgery.
Oh.
Yeah. So I also kind of was reminded of that. I think I knew that at one point in my career.
Yes, because they can almost do barium minimus for the sigmoid.
Right. So I didn't know exactly the way they would treat the sigmoid, but I did confirm with radiologists that the radiologic study was confirmatory for cecal volvulus. But looking at this algorithm, once you make a decision or make a diagnosis of volvulus, we have to decide whether is it a sigmoid volvulus or is it a cecal volvulus. If you go to the cecal volvulus side, depending on the state of the patient, if she or he is extremely debilitated or unstable, they just simply place a cecostomy, which is like a nephrostomy or whatnot. They just either surgically or IR will just put a tube right into the cecum to drain it. If the patient is stable enough to go to surgery, like my patient was, they do emergent surgery, go in to do exploratory lab, and then, like my patient, they will perform oftentimes a right hemicolectomy. Okay, or they'll do resection in a Hartmann's procedure, which I have no idea what that is. The other type of volvulus, which is much more common, is the sigmoid volvulus. Now, this type of volvulus, again, you assess the clinical condition of the patient. If the patient has no signs of peritonitis, then he or she is stable enough to proceed with the endoscopic decompensation. They can do the barium enema, like you said, or they can actually go up, GI can go up and untwist the sigmoid. If it's successful, they'll be done pretty much. And then if that endoscopic decompensation is unsuccessful, they might do surgery like semi-electively if the patient is stable and there's no peritonitis or ischemic bowel. So I think this point is actually very critical, and is incumbent upon the emergency physician to know the difference and to inform the surgeon, because it determines the route of treatment, right, and how emergent or not it is. So I think it's a very important learning point from this case. Learning focus number 2. I bet you have no clue what this is.
Probably not.
Right. So I like to do.
But I'm excited to learn.
Yeah. It's it's fun.
Dun, dun, dun.
It's fun and it's cute
Drum
and it's
coffee bean sign.
Ever heard of that?
No, I like coffee. I'm loving where this is going.
All right. So, actually, like I said, I started this EM endeavor many years ago. And at that time, we were much more dependent upon looking at plain films to make diagnosis, right? So what do you think this is? Is this a sigmoid volvulus or is this a cecal volvulus?
I'm going to say, clearly this is a sigmoid volvulus.
Well, you are smarter than me, but when I started this love affair with emergency medicine 26 years ago, we relied a lot more on plain x-rays. And so at the time we were being taught that there was this thing as called a coffee bean sign, right? So when you have the two loops kind of doubled on each other, it looks kind of like a coffee bean. That's what it was called.
I wonder if that's where they got the double bubble now.
Yep, I think that's similar. What about this one?
That is going to be a sequel.
You think?
No.
Let's see. Very good. You are definitely smarter than I am. I think this is more of a croissant sign. That's my personal nomenclature for this one. But I think what we can see is this double bubble on the plain film with a little fold right in the center. What about this next one? What do you think?
I'm going to say sequel.
Sequel?
Yes.
All right, let's
Croissant. No coffee.
Yes!
Wow.
Yeah. Well, it looks to me kind of not like either of those two in the past, and the two previous ones. But what about this one?
This looks like a combination. I feel like they have the croissant
with
the coffee bean underneath.
All right, let's see
I'm
what this is.
I'm going to say sequel.
Sigmoid.
Sigmoid! I had a 50-50.
Yeah, these are films I got off the internet. But to me, it looks like a croissant sign, doesn't it?
Yes.
Just, once again, that's my own nomenclature. It's not out in the literature, so just you guys who are viewing this, don't use that.
This is a Dr. Lee N of 1.
Yeah, exactly. What about this one? What do you think?
I still see the croissant. Maybe it's because I'm hungry. I still see the croissant. But I think you can see more of a coffee bean. So I would say this is probably more sigmoid.
I agree with you. Yay! Now there is another nomenclature, not just a coffee bean sign, which we can see very clearly here, but there's a folded inner tube sign, folded balloon sign. You can see how there's a line between the two halves of the balloon, just like there's a line between the two halves of the sigmoid, right?
It clearly distinguishes them.
Yeah, so it's kind of cute, I think. What about this one? The last one.
This is sequel. This was our patient.
Very good. This is our patient. That's exactly right. So what does this look like to you? I mean, what would you call that? Is that a kidney bean or is that a coffee bean, right? Or is it a croissant?
I think it's a croissant.
So it's kind of fun to look at all those photos. But the bottom line of doing all that is this, which is don't rely on beans for a definitive diagnosis. Okay, go to a CAT scan because it's a very, very big difference between the way you treat a sigmoid volvulus versus a cecal volvulus.
Let's go have coffee.
Yeah, exactly. Well, Dr. Harper, thank you for coming. Did you have fun?
I did. Had to remember the volvulus.
That's right. So like I said, I was also somewhat distracted by the trauma. Mm-hmm. And so when the x-rays came back, I was surprised, but I thought, oh, wow, another screencast.
Oh, definitely. You seem to find all these, and it highlights so much in emergency medicine. Mm-hmm. Some of these more rare diagnoses, you have to be thinking about them.
Absolutely.
Or you're not going to look for them.
So you've not seen a volvulus in your career?
I have not.
Okay. I was just telling one of our colleagues the other day, there's only a few uses of plain x-rays nowadays, which is, one is to look for air fluid levels, mm-hmm. 2 is to look for impacted stool, a lot of stool density, and number 3 is to look for those bean signs, if you will, double bubble or the inner tube signs, because doesn't give you a diagnosis necessarily right away, but at least will expedite, I think, your evaluation and then limits your differential, narrows it so that you know more efficient pursuit of your diagnosis.
I think it can heighten your awareness too. You know, if you're waiting for labs or if there's any sort of delay, it just lets you know this patient needs to go much more urgently.
Absolutely. Very good. Well, thank you very much for joining me.
Always.
Well, everybody, thank you again for viewing this month. I've had a fun time with Dr. Harper, and also hopefully you have learned something about volvulus and to look out for it the next time you have a patient that comes in with these kind of complaints. So we'll see you next month. Thank you. Bye-bye.
Thank you.